contribution to the Indian medicines. So हम रिक्वेस्ट करेंगे डॉक्टर वली से कि वली जी आप हमें कुछ खास बातें बताइए. एक तो डायबिटीज के बारे में जो अवेयरनेस की जरूरत है, प्लीज गिव अस दोज अवेयरनेस व्हिच वी हैव मिस्ड.
Yes, I'm audible, I think.
Yeah, Dr. Saab, perfect.
And I need to share the screen. This is not going. Just
No
give me 10 seconds and I've asked for the share option. And I think I'm on the screen now.
Yeah, you are.
Well, we are today dealing to start with the world's biggest enemy, and that is what we call it Madhume or diabetes. And as you rightly said, diabetic capital does not mean anything more than that we have to be careful for the future generation. It is caring for the generation. And I would congratulate Mohan's Diabetic Institute with a battery of doctors and experts and competent people. Mohan's Diabetic Institute is first in many things. And last time when I was president physician, I remember that Abbott's glucose sensor device first reached to Mohan's Institute, and they were first in it. And there are many firsts to their credit. And Madhume is known since the time of Charaka, and Charak Samhita mentions Madhume. This is an age-old disease in which urine becomes sweet and called diabetes mellitus. Mellitus means sweet. And I would wish Medgate to continue these services at least monthly. And here we see HMD at the background of Dr. Rajiv Nath. And this is Hindustan. This is Mera Hindustan and medical devices with Hindustan. And I thank Dr. Rajiv Nath ji. And Rajiv Nath ji is a very generous person. And he always mentors us and mentors Medgate, and his association with my good friend Afzal Kamal is a very, very great association, and I'm part of your team, sir. Dr. Rajiv Nath, you are a great man and you have a vision. I appreciate that, and I would continue this medical education for this diabetes, because everybody needs to control the blood sugar. And your famous syringes are very well known, and Dispovan is very well known name all over the world. And I am just very sure that these syringes are being used in COVID vaccination. And I asked you this just now and you confirmed it. And we have with us luminaries like Dr. Uttara, Dr. Mandeep, Dr. Lavlina, and they will probably give you more academic inputs. I am a layman as compared to you experts. This diabetes is a very, very bad disease. And type 2 diabetes, as you rightly said, is a growing global problem. It's 6% of the world population is suffering from the disease. The risk of developing the diabetes can greatly be reduced by weight reduction, eating correction, and exercise. This is one of the manageable problem which we, by inactivity, by eating wrong, and by not following the day-to-day life as Indians should follow, are increasing. Forget about Western countries. We should not adapt their diet and early detection. Today I was very fascinated. I'm going to show you how I was fascinated. Early detection of diabetes type 2 would minimize a lot of health complications in the later life. And as a layman, I can say I'm a student still. When you are healthy, your pancreas, an organ behind the stomach, releases insulin. This is more so for audience, not for you, the panelists. And your pancreas either does not produce insulin, the pancreas makes very little insulin, sometimes more, and your body doesn't respond the way it should when the insulin is adequate in the blood, measurably adequate, but it's not affecting on the end organ, target organs. Unlike the people with type 1 diabetes, people with type 2 diabetes, they make insulin, but the insulin their pancreas releases is not enough on their body. The body cannot recognize, the cells cannot recognize the insulin and use it properly. And we call it as insulin resistance. And not everyone with type 2 diabetes has essentially the obesity and inactivity in the lifestyle, but these are two very common accompaniments. And 90 to 95% we see at the background that people are obese and inactive. And now we are seeing an addition. Our friend in Delhi, Dr. Mishra, Anup Mishra, has said that 7% incidence of diabetes increased post-COVID due to steroid use and COVID effects on pancreas. And you must be studying it in detail, how COVID has affected cells of the pancreas. Then this is a condition which is pre-diabetes. This is an intermediate state, and it's our duty to catch the diabetes young. And one of the markers, we are using this, we have used this for COVID, it's high sensitive HSCRP, which can detect the inflammation on the body, which can go to the pancreas, precipitate the diabetes. And this, I came across this paper, Datta Meghe Institute, Varda, and they have done work on this. Same way, one of you must be talking about diabetes in a newborn or young neonates, or congenital diabetes, or diabetes mellitus of newborn, and the incidence is quite low, though it should not be missed. 1 in 90,000 to 1 in 160,000 live births, and there are many causes. We sometimes say diabetes autoimmune condition, it's an inflammatory condition. And in children, newborn, neonates, these are some of the signs which I just wanted for me to revise. Bluish discoloration or pale skin, breathing problems, feeding problems also, and irregular breathing, rapid grunting sounds, irritability in the child, listlessness, or parents may be diabetic, loose or floppy muscles, poor feeding, vomitings, problems keeping the body warm. These are some of the mutations which I learned while making this PowerPoint, and they were named mutations. You must be knowing more than me. KCNJ11 and ABCC8. These are the beta cells affecting mutations, and this affect the ATP pathways, and they can be treated. This was important why I tried to bring it over, that high doses sulfonylurea may be considered in these very young patients. Then genetic overexpression like 6q24, these are the genes. They can cause either permanent or transient neonatal diabetes. Antibodies for type 1 diabetes should be drawn, including glutamate decarboxylate antibodies, zinc transporter 8, ZNT8 antibodies, islet antigen antibodies we were taught. Islet antibodies we were taught when we were students. Then I have come across a very interesting thing. This is follistatin. This follistatin is something which is being used like erythropoietin in horses. And the applied importance of follistatin in that Sweden, this was a paper recently one friend of mine sent me. And this is the structure of follistatin. Follistatin was found by Sweden researchers at Lund University in a new studies, and they were doing the research for some other purpose, and they found that this was a series of the patient who developed later on diabetes. This was found to be high, so they caught it. And what they known is this is the structure they tried to show, and also known as activin binding protein. There are a lot of publications of follistatin these days, and they're working in the direction that many years prior to the diabetes, follistatin levels are increased. This sounded to me very impressive. And they have one study published recently in 5,318 patients of various age, and this was taken up positively. And this can be the future test, like we have cystatin C in the kidney disease. Previously, we were not doing cystatin C, and now we are doing cystatin C. So this could be a marker, and the details will follow in the days to come. But we have to really devise, Dr. Nath and my panelists, I'm very, very perplexed that when 30% of the pancreas gets damaged, as per the standard textbook of diabetes, we develop diabetes. So before that 30%, what will happen? Nobody knows. So people have to know, like a coding, when they're going to have diabetes, if so, if that is the case. And this is that the detail that how they found their genomic association, and what was the biomarker they predicted for future. And this was very interesting to me. That is why I brought it. You just remember follistatin for the future. At present, this is being used for bulls. There's a bullfight like Texas, they have bullfights. And this is not being used so far. It is available in vials, that is available, quite costly. And they are using for some experimental indications on myopathies in which there is a muscular atrophy. So very selected cases of myopathies, sarcopenia, and maybe if this was approved, I could have used. I have lost a lot of muscle after COVID. That was autophagy. So a lot of people have lost their body mass during the COVID. I don't know, and when this will come for the help of people who lost muscle, and for the myopathy patient, this would be the future. This was a research paper in which they injected directly into the quadriceps muscle, and you can see the growth of quadriceps muscle. They were the creatinine kinase markers and cytomegalovirus combined with follistatin markers, and they found that muscle growth was very effective. Fibers become dense, fat becomes less, muscle grows. So this was the histology. So they have also done genome-wide association study, GWAS, and the same number of people. And they found that this was important, that they found that glucokinase regulatory protein GCKR has an impact on the metabolic traits. This was interesting. This may be talk of tomorrow with reference to diabetes. Then when we were students of MD in 1979-80, metformin was banned. And there was a lot of hue and cry that metformin causes side effects, toxicity, and cardiotoxicity and whatnot. But now this metformin is coming up beyond diabetes as an anti-aging agent, as a molecule of tomorrow, helpful in dementia, and so many things. There are TED Talks about metformin all over, and this could be the future molecule as an anti-aging molecule, and so many other benefits. So remember, once metformin was banned, now researchers suggest that new indication and a recent revelation about metformin, it is being promoted as a large-scale trials as an anti-aging molecule, and they have done the research on telomeres and telomeres research, and this could be the molecule for tomorrow. But those patients who are having metformin for diabetes, they have benefits. So metformin is the molecule of tomorrow, and uh, I can now stop sharing and I can talk to you in person. And this was it. So thank you very much for incorporating me in this talk. I just had these two exciting things which I mentioned. I don't know, tomorrow when you will grow up, they will be used as a standard test, and metformin as an anti-aging drug with reference to diabetes. And I'm very happy to be associated with this talk. And I will be learning more through the experts. And I'm a student myself, and keep learning every day. And just now I learned about the this combination of Omicron and Delta virus. Somebody told that there can be super virus combined with two. So every day new things are breaking up. And I wish you all a good health. I wish all the audience a good health, free from corona, free from Omicron, and wish you a very, very happy Christmas and a new year in the days to come. From Medgate, from HMD, on behalf of Dr. Rajiv Nath. And I wish you lovely days ahead. We have suffered really so much during last 2 years, and we have suffered beyond imagination. The world has suffered beyond imagination. So I wish everyone participating a very good luck. And thank you very much once again. Thank you, Dr. Rajiv Nath, for being a mentor. And I wish you will be giving us chances to help you and to express our gratitude further, can keep this program going, which would be for the good cause, as you have been doing always. And I wish Mohan's Institute also a grand success, and they are doing great work for diabetes research and treating and earning a good name all over the world and publishing lots of academic papers. I keep reading the good work they are doing. And thank you very much. And I wish again a very happy new year to all of you.
Thank you so much, Dr. Saab. It was really a pleasure to hear you. and it was so insightful. We could really make out so new things about the corona, and again the after effects of corona and the diabetes. Everything we just mixed up, and it gave us a lovely insight about the entire thing. Thank you so very much. I'll be asking you questions if you stay along. I hope you will be there with the session with us throughout the
Yeah,
session.
I have another TV talk at 5:30, so I'm there till 5:30.
Oh,
Don't worry.
okay. Then I'll be asking you a question soon. In the meantime, let me introduce Rajiv Nath ji. Rajiv Nath is the Joint Managing Director of Hindustan Syringes and Medical Devices, as well as is the founder of Association of Indian Medical Device Industry with over 350 members nationwide. Mr. Nath has taken many initiatives of establishing a collaborative framework with various departments of government and media to bring to their attention issues troubling the industry and attract investment into India and its best to make India as the preferred manufacturing destination and the leading supplier of medical device worldwide. So we have heard about the syringes, we have heard about the pen syringes. So I would really love to know more from Rajiv Naji. Sir, I hope to see you on the screen because I can't see you here. Yeah. So let's hear it from Rajiv, sir. Welcome,
Thank you
Rajiv,
so
sir.
much, Dr. Yogita, for hosting and moderating this today's webinar. And I thank Dr. Wali for setting the pace. Very insightful presentation. Every day we are learning, and today many of the slides gave very interesting scientific data about diabetes and how it can be caught on 19 years before you can potentially get it. Amazing science. I also thank Dr. Munava, Dr. Utra, and Dr. Acharya for joining in, and we look forward to listening and onto their expert views. I myself am diabetic. Every day I take insulin. It used to be 30 units every day of Lantus. Now it's reduced down to 18 units. I've been having it diabetes since I was 45 years of age. Now I'm nearly 60. So nearly 15 years I've been on medication, first oral and then on injectables. And I've realized over a period of time that it is not a disease. Whether it is heart or whether it is diabetes, both need to be managed, and both can be managed. So today, like everybody else on the show, I'm as eager as everybody because even I'm a patient. I'm as eager as everybody to understand how it can be managed well and how we can have a normal lifestyle or a healthy lifestyle and what precautions we can take from triggering potential hazardous, I would say, status of diabetes over there. As far as HMT goes, we've been making syringes for all kinds of usages, including syringes for 1 ml for diabetic use with 40 ml units marking and 100 unit marking, depending on the kind of medication you're using. We've also introduced a couple of years back the very first insulin pen needles. Earlier, India was import dependent upon syringes, and India was import dependent upon insulin pen needles. And I was myself using imported products. And then, of course, that's not a good thing to keep on depending upon imports. So we decided that we'll invest in technology and we will start making our own needles and make them affordable for everybody. So we did that. The cost of the needle which we are selling in the market is less than half of what was available in the market. So people who were tending to reuse needles because they were so expensive. I know when I started, even myself and other patients were reusing needles 1 time to 4 times to maybe even 5 times, 6 times. Because it's now locally available, we can use it singly. It becomes painless if you don't have to reuse it because the needle point is not damaged. And most important, I found that when I was using the needle on myself, I realized that the pain factor is not coming so much from the needle. It comes from the speed of the injection of the insulin into the body. So if you inject slowly or inject fast, the velocity and the flow of the needle is what is basically causing the pain, not the entry of the needle inside the body or removing the needle from the body. Over to the experts now, and I look forward to learning from you all. Thank you so much for joining in. and thank you for sharing your expertise. Dr. Mohan's hospital has always been at the forefront of diabetes care. It's been more than, I think, 30 years since we have an association with your hospital, since it was founded by the initial founder, Dr. Mohan, and his son is now doing a stellar job also. And you've got a great team here. I'm very happy that the team is taking the flag forward for the brand over there, not only for South India, but all India. Thank you so much for joining in.
Thank you so much, Dr. साहब. मेरा एक सवाल था, I really wanted to know about these syringes, पर आपने खुद बताया कि when you were 45, since then you have been taking the insulin और आप needles का इस्तेमाल तब से कर रहे हैं, तो the question कि how safe it is, it vanishes eventually, the way you just told us, so it just vanished. पर फिर भी बहुत से लोग ऐसे हैं, उनके दिमाग में हमेशा ये inhibition रहता है कि कितना safe है to use these syringes, how safe would it be? So उनके इस क्वेश्चन का आंसर I know you're a live example about it, but still I would love to hear it from you कि अगर एक आम आदमी जानना चाहता है तो उसको कन्विंस करने के लिए what should we say? How safe is it to use the needles?
Well, the product is made completely automatically on automatic machines, untouched by hand. More than 500 syringes per minute are being assembled in a minute's time. That's a stupendous speed. और जो नीडल पाइप है हम खुद बनाते हैं, उसकी जो ग्राइंडिंग है ऑटोमेटिक मशीन्स पे हम खुद करते हैं. एवरी पॉइंट ऑन द सिरिंज और ऑन द नीडल, it is checked by digital vision systems automatically. It expands the image of the needle more than 60 times, compares it to a theoretical image. If the point is blunt or hooked or damaged, or by mistake it is upside down assembly, or it's a block needle, it will be removed automatically. So we try to make sure that zero defect goes to the market. My company runs on a Six Sigma principle. So that means that 1 in a million pieces defect can reach the market. So we work progressively on the management part, because you may have the best technology, but if you don't manage it properly, it'd be an issue. The products are then properly sterilized and packed in a clean room, so where the bioburden is very low. So even though sterilization can kill the bacteria, the whole purpose or the prevention part for a clean room is bacteria should not be on the product itself, because a dead bacteria also can cause a toxic reaction or a feverish feeling after getting an injection or an IV solution. So by keeping a hygienic atmosphere in the factory, we try to ensure that such kind of pathogens or feverish feeling does not occur to the patient. ठंडी लगनी चाहिए इंजेक्शन के बाद, ना दर्द महसूस होनी चाहिए. And those days when I was a child myself, I've been getting injections from non-disposable needles which were sharpened on stone, and we used to get an abscess. It used to be very painful. Those days are gone. Now for COVID, many people have taken injections after many years, and they've come back and told me that we could hardly feel the injection going forward. So I'm pleased that our engineering team and our production team is doing a good job on that. Thank you so much.
Thank you so much, sir. Thank you very much. अब बहुत देर से बात हो रही है डॉक्टर मोहन्स डायबिटीज स्पेशलाइजेशन सेंटर की, तो लेट मी गिव अ स्मॉल इनसाइट अबाउट देम. डॉक्टर मोहन्स डायबिटीज स्पेशलिटी सेंटर is a diabetic specialty hospital chain with its headquarters in Chennai, and the founder is Padma Shri Dr. V. Mohan, along with his wife Rima. They are taking care of the center, and Dr. Mohan's Diabetes Specialty Center is a collaboration center for WHO on non-communicable diseases prevention and control. So we are having 3 experts from that hospital. They are going to give an insight about the diabetes, so you can put across your questions. To begin with, I would request Dr. Uttara. She has been working in the field of diabetes exclusively for more than a decade. Subsequent to graduating MBBS from SRMC, she has received extensive training in diabetes at DMDSC Chennai and received her fellowship in diabetology. Now she has completed her PHFI certified course on Gestational Diabetes mellitus by FPHFI. This is what has been written. And now I would request Dr. Uttara to give an insight. She's been working on women and diabetes. लोगों ने बहुत सुना होगा कि प्रेगनेंसी के दौरान डायबिटीज हो जाता है, and after the delivery it has been controlled in few of the cases it's not controlled. बहुत सारी controversies है, बहुत सारे सवाल हैं जो लोगों के दिमाग में रहते हैं. So we are going to talk about that. Dr. Uttara, I would request you to start up.
Yeah, thank you, Dr. Yogita, and good evening all, and I welcome you all for this wonderful evening. I think we have a lot of eminent personalities here, and it was a pleasure to listen to both my previous speakers. And I think for want of time, I would just go directly to the question. Yeah, women and diabetes, you said, there are a lot of controversies involved. Where there is women involved, I think there should be controversies involved. And so it's always from starting with, a diagnosis and in diabetes and all. But it's not very different between men and women in diabetes in terms of diagnosis and so on. The common symptoms like increased thirst, the 4 T's they call it simplified, increased thirst, increased tiredness, increased toilet, and becoming thinner, increased thinner. So the 4 T's, that kind of common between men and women. But what a little more so is that men trying to lose a little more muscle mass, and then they can get kind of genital, infections and what we call balanoxitis. That's when we pick up diabetes in men. But in women, it is more or less, PCODs or irregular menses, and again, all the common symptoms, and sometimes urinary tract infection. That's how we pick up diabetes in women. But according to, the International Diabetes Federation 2018 data, there are almost around 199 million women with diabetes. This is 2018. I'm sure the clock is ticking, and we have crossed that 199 million far out yet. Women have their own challenges, when they come to, even diagnosis or it can very variable according to the, the socioeconomic status across India. India as such is a very heterogeneous country, and you can't really generalize every woman. And there are women who can sit and discuss a lot of things, but then women who cannot even, go ask for a blood test at home. So a lot of things, but they do have a higher chances of heart disease when compared to men. So the heart attack rate or the mortality after that is a death after a heart attack is a little more higher in women, especially when they cross menopause, when they cross the age, because of a lot of hormonal changes, they have a very high risk of developing heart attack. And the risk of depression is little more. I'm just talking more in comparison with men. It's not a difference, you just where they stand. So depression risk is quite high. Even the retinopathy complications, the commonest complications of diabetes, the eye, kidney, and then the limbs, neuropathy, and so on. Even the eye complications a little bit more so in women than in men. And of course, there comes the the dubious challenge of pregnancy, where it is a big boon and yet also a huge russian of hormonal disturbances, and a lot of things just happen, bodily changes happen to women. And pregnancy and diabetes, you can either the women can be early diabetic, they already had a type 1 or type 2 diabetes, and then they develop and then they become pregnant, or they can develop during pregnancy. They could have been a non-diabetic, a normal adulthood, and then they develop diabetes during pregnancy. So developing diabetes during pregnancy is what we generally hear as gestational diabetes mellitus, as Dr. Yogita did ask me about. So it is gestational diabetes mellitus means you develop diabetes, the women develop diabetes during the pregnancy. And the common thing that happens about that is that it disappears after pregnancy and so on. Before we get into that, the diabetes during pregnancy, the very important thing about women already being a diabetic and developing, and then becoming pregnant is that the initial period is very important. By the time they get pregnant, they do a preg card or, go test for pregnancy. Most of the organogenesis has happened. Not their development has happened. So, it's preferable if the woman knows that she's a diabetic to get her sugars under control, even pre-conceptionally, before even she gets pregnant. That kind of really sets the stage very well for the woman, and she can have a very uneventful and happy pregnancy and delivery and so on. Now that the woman wasn't a diabetic and she wants to know whether she is diabetic or not, definitely testing is the thing. So coming to testing, again, there are a lot of controversies when to do the testing in a pregnant woman. Should we do it as soon as the women diagnoses pregnancy, or should we wait till 24 to 28 weeks and so on? But then there was a recent not so recent, a trial called the IADPSG kind of clarified most of these doubts which we had earlier. And even our center at Dr. Mohan's Diabetes Center, we did a very big trial called the WINGS project, where we looked at women in the pregnancy scenario and the gestational diabetes scenario, and we thought what guidelines would work best for our Indian women. We can't just blindly follow the Western guidelines. So because Indian women and Indian population are unique in their own way, so we could just not copy the guidelines. So we had our own trial patients, and then we looked at, followed up all their pregnancies. And so the WINGS project, what we found out is that Indian women are very much prone to diabetes. So as soon as the Asian Indian population, we call it, they have a very unique genotype and phenotype, that is their gene and their body nature. Gene, that is the genotype, and the body nature is the phenotype. This is very unique for the Indian population. So that is why we think that the women, once they, at booking, we call it, that is once they diagnose pregnancy, it's preferable to do a GTT or a glucose tolerance testing, unless until it's contraindicated. Otherwise, it's preferable. Most of the gynecologists are very well comfortable with doing that. The biggest challenge comes, when they're very far off, the interior of a country, and they cannot travel to the thing. And there are still in India, there are places where women, are doing pre-nuptial counseling and all that. And there are places where the women only come to the hospital or don't even come to the hospital for a delivery. So, in a forum like this, we cannot differentiate all the group of people. Sorry. But then that is the challenge. If they're not accessible to a lab, then okay, fine, you do it at 24 to 28 weeks. But if you are accessible, if the woman is accessible to a lab and she can get access to blood testing at booking, at knowing that she is pregnant, I think do a testing to know whether she's diabetic or not will be the ideal thing. But then usually, if it is a gestational diabetes, somewhere around 24 to 28 weeks of a gestation, the period of pregnancy, that is when she will develop diabetes. That is because of a lot of hormonal changes, placental hormone, we call that, all that, the counter-regulatory hormones, there's an interaction between a lot of the good and the bad hormones. And that's when usually at around 24 to 28 weeks is when the women will start developing diabetes. So definitely should not be missed. 24 to 28 weeks, definitely a GTT should be done. So then we will know whether she is a diabetic or not, and then the plan of treatment. And then on delivery, when it comes to delivery, as long as she has maintained her sugar very well, there is no, a strict rule that she has to go in for a cesarean section or so on. That it depends on the other obstetric complication. Diabetes per se, it is not an indication for, cesarean section. There is a lot of stigma about cesarean section either way, People do want to fix the time and date and all that, get a cesarean section done also. And there are people who want to do it, the all natural way and so on. So it cannot debate on either one, but diabetes definitely is not an indication for cesarean section. Can be an additional factor along with other obstetric complications, which definitely the obstetrician or the gynecologist is going to discuss with a woman. And then after delivery, that's the part I really want to, discuss with you all, is that if she had been a gestational diabetes, the pregnancy complication, as long as the sugars are maintained very well, she's been consulting a diabetologist quite regularly, and she's been visiting her obstetrician gynecologist quite regularly, very unlikely that she will develop any complications, both for her or for the child and the neonate. But in some unfortunate situation and so on, they can develop something. Most common is macrosomia, where that is a big baby. Okay, some babies, they tend to be more than 4.5 kg, but above 4.5, it's not considered as a really healthy chubby baby. It's not like that. It is, it can be a reason. One of the reasons could be high blood sugars in the maternal the mother's high blood sugar, which had caused this big baby. There are a lot of other things also which can happen, like, sacral agenesis, shoulder dystocia, and so on, getting into that. And the mother also, during the pregnancy, if she had very bad blood sugars control, she can also develop high blood pressure. So both has to be monitored. Her weight, her blood pressure, and her blood sugars has to be monitored very well during her pregnancy. And then once she delivers, as I said, it can be a cesarean section or a normal, very well a normal delivery also. So after a normal delivery, everything like the kid needn't be in a neonate ICU or so on. Just the blood sugar should be checked, especially in women who are on treatment for diabetes, they're on insulin or so on. Then just neonate should be checked for hypoglycemia, low blood sugar. Other than that, if there is no hyperbilirubinemia or jaundice or anything in the child, she can feed the child immediately. Breastfeeding can be done, and she can feed the child immediately, even if she has diabetes and so on. So the coming to the part that after delivery and everything, she just start from home. She's happily with her baby at home. After 6 weeks, definitely she has to get a GTT done, because most of the time the blood sugars will become almost normal or zero. I mean, normal non-diabetic levels post delivery. That's because the placenta, after the placenta comes out, the hormonal changes, all that gets back to normalcy as her old pre-pregnancy levels. And so when she checks her sugar, 99% of the time it would be normal, unless until she was a diabetic who was already a diabetic and didn't diagnose it, and only during pregnancy we picked it up or something like that. There are few who will continue to be diabetic, but unless otherwise, most of them will become non-diabetic post delivery once the baby and the placenta comes out. So that's when we don't really ask her to keep checking the sugar too often and all that. It's going to be a real handful with her newborn and breastfeeding and so on. But at 6 weeks, with all the discomfort and so on, at 6 weeks, she definitely has to come back and get a GTT done. And with all the newer facilities available, we do also have a home care facility and so on. At least a home care testing of a glucose tolerance testing, just not a one-touch prick. It's preferable to do a glucose tolerance testing, that is taking a glucose syrup and testing it, because that's when we can pick up even the pre-diabetes levels. So because that is also quite important to reassure or warn the women about how early or how late she can develop diabetes. You might be really surprised to know that almost around 50% of the women who were gestational diabetic, who had diabetes during pregnancy, almost within 5 years they become type 2 diabetic. So it is a very high risk. So after 6 weeks, if they do not have diabetes, very good. Every year it is preferable to annually get their blood sugar checked. And they should always have in mind, it's not necessary that they will develop diabetes, but at least they're a little on the high risk group compared to a pregnant woman who did not have diabetes during the pregnancy. These women do have a little higher risk. So they're going to be a little cautious and vigilant about her diet plan, about her exercise, and then get an annual workup done. Probably she can postpone it as much as possible, or totally get away from it without being diagnosed diabetes later in future. I think I would stop there, and probably if I can go on and on, I didn't want to do that. I have two more very good speakers following up.
It was really lovely to hear you, because you just subsided all my questions which I was planning to ask you. But there's one question which I really would love to ask you. When there's a woman who is pregnant and she has been diagnosed diabetes, now she's at a position where she needs to take medicine also. Most of the time in Indian families, parents, they keep asking that stop, don't take medicines right now, because once you start taking the medicines, you have to carry it on throughout your life. So this is a question which usually the Indian society has the mentality. They say, let's go to the other mode of treatment where they are going to give you something and you will be all right. Let's eat curry patta, let's do this. And we tend to follow those. So how risky would you feel that this can happen this can affect the fetus, the mother, both? I mean, if we really don't take care of the medication part.
Definitely, that's a very good, valid question also, because they somehow feel, it's insulin or, medication is something addictive, and, it's like something it's going to be addictive. Once you take it, you will live with it lifelong. And this is a question all three of us do face every day in and day out, in our patients. This is more so with insulin. But then, in pregnancy, somehow, they are the most compliant of patients, the best, sweetest of patients we have are patients who we have during pregnancy, it's because they are so worried about the child inside that they can go to any extent. I tell them to stand upside down every day. They would do it for me to get the baby, healthy and very healthy baby. So I haven't had issues in pregnant women at all, because they're very fine as long as we are explaining to them that whatever we are trying to do, or why we are controlling the blood sugar, to get the control, blood sugars under control can help them have a very smooth and uneventful pregnancy, and the baby can come out like a diabetic pregnant baby. So they are usually okay with it. And in terms of, in that note, I just do want to say, right now, usually metformin and insulin is what we do use during pregnancy, and insulin is very safe during pregnancy, and it is a 100-year-old tested medicine. So it's with essentially year of insulin. I don't think you can have any more evidence about any drug. If they had to find out anything bad about it in 100 years, if they can't find out, I don't think they're going to find out in the 101 year or so on. So I think it's quite safe to use insulin during pregnancy. And if not, like I said, in unfortunate situation where the blood sugars haven't been controlled, they can have a lot of complications. Starting in the mother, they can have something called preeclampsia or high blood pressure, which can lead on to pressure building up inside, and that can lead on to bleeding, premature babies, so premature deliveries. So that can lead on to abortions, spontaneous abortions, and so on, much earlier on, later on into premature babies, and so on. And then in the baby, again, as I told you, macrosomia, or the after delivery hyperbilirubinemia and sacral agenesis, we call it. That is also a very pathognomic of diabetic pregnancy. All these are in very high blood sugars, uncontrolled diabetic. Otherwise, the commonest, if you ask me, the commonest day in and day out in an uncontrolled, what we hear is mostly, maximum is like usually macrosomia, not more than that, thankfully. But there are a few who are really, assessed to treatment and so on, where the complications can be really deadly, as much as, death to the maternal death and fetal death. Actually, diabetes also is one of the contributors for maternal and fetal death, that is the mother's death and fetal death during pregnancy, one of the big contributors. So it cannot be taken lightly. So in a forum like this, I didn't want to scare people around about diabetes. It is that I want more and more people to come out, check their blood sugar levels, and if diagnosed quite early, they can really do a lot of good things to the baby and herself. So that is why I didn't really go into the total detail of the complications of pregnancy and diabetes, but if ignored, can really cause havoc, and definitely it is not a condition which could be ignored. And yeah, I think I did answer the part of your question about being habitual and so on. So it is like, this is a common question. I think Dr. Rajiv, everybody would have heard, should I take the vaccine or not? And should I, it's like that. Does it not do harm for you? And so on. It is always weighing it, because I can't explain to my patients the benefit of, for want of time, the benefit of insulin and so on. But I do tell them, if you don't keep your sugars under control, the complications and so on and so on. And if you take insulin, you do get your blood sugars under very good control, and there are no complications in taking medicine or insulin. And it is a weighing of your pros and cons. So definitely, day in and day out, we do meet Dr. Manodeep or Dr. Lavlina, all of us, we do meet a lot of patients with complications of diabetes. With all our years of practice, we hardly meet anyone with complications of medication, because they took too much of medication. Hypoglycemia, yes, too much of insulin, or so that's a correctable complication or treatable complication of over medication. Other than that, untreatable complications of medication, we do hardly meet. But again, it is a balance. So it is going to be the discretion of the doctor to decide how much medication the patient sitting in front of me needs.
Yeah, thank you so much, Dr. Saab. Thank you so much. I'll be asking you more questions. But now let's meet Dr. Manodeep Acharya ji. And he has passed out from Nil Ratan Sarkar Medical College in 2000. And he has worked in different organizations, different hospitals, like he worked for Apollo. He completed his master's in diabetology from Eton University. It's an American university. Then he returned to Calcutta, joined Dr. Mohan's Diabetes Specialty Center, and which is a #1 diabetes-based comprehensive treatment in India. He's a consultant diabetologist, and now he's currently practicing in Siliguri. So, doctor, I would request you to join us, because I really need to know about continuous glucose monitoring. What is it and how should it be done? So I would really request you to give an insight about this, about diabetes reversal and the modern insulin therapy. So can I have you on the screen, Dr. Saab? Yeah.
Am I visible?
Yeah, sir. Perfect.
Okay. Good evening. Namaskar. Thanks for having me and welcome you all. And it's a really pleasure to be in this August session. And I'm really enlightened by Professor Dr. N. Wally's excellent presentations regarding the latest developments, research going on in the field of diabetes. Yeah, it's a lovely topic, which I think is a paradigm shift in the evaluation and the management of diabetes per se, if we consider it both the type 1 and the type 2 diabetes. Now, next the question comes is, there are two concepts. One is SMBG, self-monitoring of the blood glucose, and another is the CGM, the continuous glucose monitoring, flash glucose monitoring. So SMBG is what we understand in layman term is when we check the blood sugar through the glucometers. The patient checks it, the doctors, whenever he's in the hospital, the doctors check it, the nurses check it. So that is called SMBG. So SMBG, if we can compare it in a context of, let me give you an example, that SMBG or the glucometer blood sugar, that is, I can call it as a still picture. But whereas we are doing a continuous glucose monitoring, we can call it as a video picture. Obviously, there is some magnanimity with the video picture in comparison to the still picture. So we were happy with the SMBG, self-monitoring of the blood glucose. Then why came this continuous glucose monitoring came into the picture? But before that, I want to tell you that what is continuous glucose monitoring? It's a continuous monitoring of the blood glucose like we used to do in case of the ECGs, the Holter monitorings or the ambulatory blood pressure monitoring. So also we do this continuous glucose monitoring, in which what we generally do is we have a sensor and there is an applicator. Through this applicator, the sensor has been put on the back of the upper arm. Sensor is there and we are allowed to do the normal daily activities, including taking showers, sleeping, walking, and all. And we have a reader with it, and the reader is connected with this sensor. And whenever we bring that reader, the switched on mode, we bring that reader within this 4 centimeter distance of that sensor, the reader will be able to catch the blood sugar reading. Now, there is a controversy regarding it, whether we are checking it the blood sugar. Normally, we are not checking it the blood sugar, we are checking it this interstitial fluid. There is also sugar in the interstitial fluid. We are checking the interstitial fluid, which is comparable with the blood sugar. So normally, through this reader, we can check at least 100 blood sugar values in a day, and that sensor is kept on the back of the upper arm for 14 days. So we are getting 100 blood sugar values in a day, and that too without having a single finger prick. And for 14 days, we'll be getting something around 1400 blood sugar values. Then whenever the 14 day is complete, the reader catches all the information from the sensor and the sensor is then removed. And when we attach that reader with the computer through their software, the results are, we are getting the results, and the results are interpreted in the forms of graphical representations. So we do, there is an extensive amount of graphical representations in which there is a vivid description of the blood sugar values in each hour of a particular day. Suppose my continuous glucose monitoring started from today. So today at 6 p.m., what was my blood sugar? I will be able to collect the data after 14 days from that graphical representation. So after doing an extensive study of that graphs, we come out with certain indices, certain matrices, and why those matrices are important, because that tells us how that particular patient's blood sugar was behaving. Now, maybe at one day at 6 a.m., his blood sugar was falling. It is far below the normal value. Then on some day after lunch, it was far above the normal value. So there are certain indices called time in range, time above range, time below range. Normally, we adjust the time in range between 70 to 180. Means the blood sugar ideally should be kept between 70 milligrams per deciliter below up to 180 milligrams per deciliter. So our aim is to keep the blood sugar value of that particular patient by tablets, by insulin, or whatever, to maintain within this time in range zone. So ideally, the time in range blood sugar values within that 14 days examination period should be at least 70%, if not more. If this target is achieved in time in range, that means why this time in range 70% is important, because that will help us to mitigate the obvious complications of the diabetes, which will eventually develop in the later period of life in the form of either cardiovascular disease like heart attack, heart failure, and all ischemic heart disease, in the brain like stroke, in the eyes like diabetic retinopathy, in the kidneys like diabetic nephropathy, in the nerves like diabetic neuropathy, in the peripheral arteries of the body like peripheral arterial diseases. So extensive research has been done all over the world. And after that research, the people have come out with this concept of keeping this time in range in at least 70%, the more the better. But it should be at least 70%. The blood sugar should be between 70 to 180. Now, what is time above range? Means the blood sugar is going above 180 milligrams per deciliter. So there are two levels, level 1, level 2. Then time below range. That means blood sugar is going far, far below. That is below 70 milligrams per deciliter. So why this time in range, time above range, time below range is important? Because it tells us the true story, what is happening inside our body over the last 14 days, and help us to mitigate the glycemic variability. Sometimes it is going too low, sometimes it is going too high. So with this yo-yo effect, that is creating too much of havoc inside our body to different systems with the development of different complications that I have told you. So to mitigate these complications, this continuous glucose monitoring, and by evaluating the results of the continuous glucose monitoring, helped us enormously that, so his time in range is not in the, it may be 30%, or it is 40%. My target is 70%. Then on some particular day before breakfast, his sugar was pretty high. Then I have to think about that what dose modifications I can do so that the high blood sugar can be brought down to normal. In some days at night, at 2 or 3 a.m. at night, the blood sugar is going down. That means there is some problem with the diet. There is some problem with the exercise, that the patient might have done too much of exercise on the preceding night, or there is some extra insulin the patient has got. So we have to adjust the dose. So we can do this post-mortem by getting this report. Previously on the SMBG, self-monitoring of the blood glucose, we used to get the blood sugar value on that particular moment only, but we didn't have the entire history of 14 days. So in that way, it is revolutionizing the management of both type 1 and type 2 diabetes. Sometimes what happens, we have seen that patient has come up with a report showing blood sugar value of something, and his glycosylated hemoglobin, that is the average blood glucose value over last 3 months, HbA1c, which is showing something. Now the blood sugar value on the immediate last day and the glycosylated hemoglobin value are not matching. So there is discrepancy between these two values. So where might be the problems? So that is that prompt us to look for the continuous glucose monitoring. In case of the type 1 diabetes patient, obviously there is huge fluctuations of the blood sugar. There is sometimes very low, very high. And the more these fluctuations, more will be the complications. So we have to mitigate this. So we have to take result of this continuous glucose monitoring. In some type 2 diabetes patients who are poorly controlled, they are taking multiple medications. And even then, the blood sugar is not controlled adequately. We have put them on insulin, even it is fluctuating a lot. So we have to control it. So we need a particular data, why it is behaving erroneously. So for that, continuous glucose monitoring is needed. The take-home message is, the less the fluctuations, the less will be the complications, more will be the complication-free life, and more will be the quality of life. So to improve the quality of life, to lessen the complications in a diabetic patients, we need to take result of this modern or technological developments, one of which has come up with this is the continuous glucose monitoring.
Lovely. So it was really lovely to hear it from you. I actually wanted to ask you a question about the fluctuating diabetes, how it's going to, how can we control this fluctuating diabetes, since you are working on the reversal of diabetes. So how to get a control or check upon this, since you said the instrument can be put across and you can, make out the fluctuations happening. But now this fluctuations, once you come to know that the fluctuations are there, this is going to cause some error in the other body portions also, other body parts also. Now, how to take care of it? What should be the management? I would really love to have the answer from you, but I would really first request Dr. Lavina Munawar to be, on screen. Let me request her to be on screen, because we are, shortage of time also. We are having lots of questions also. So Dr. Lavina Munawar is a consultant diabetologist at Dr. Mohan's Diabetes Specialty Center. She passed out from Annamalai University. She has done PhD diploma in diabetology from Cardiff University, UK. And gestational diabetes and type 1 diabetes is her field of interest. And she has won Excellence in Diabetology Award at Rotary Youth Leadership Awards. So she will be talking about diabetes, the signs and symptoms, and how can it be revised. So Lavina ji, I would love to have you on the screen. Can we hear it from you? Yeah. Welcome, ma'am.
Am I audible now, Dr. Yogi?
Yeah, perfect. Yeah, perfect.
Good evening, all. I know we are running short of time, so I just thank you for inviting us. And I just want to get into the topic directly. I think the signs and symptoms has been described by Dr. Uttara very well. So I'm going to talk about the reversal of diabetes, because even our doctors and even most of my patients and everyone is interested about the reversal of diabetes, because it's everyone is talking about. It's on social media. The moment you open, am I audible?
You're perfect, ma'am. We can hear you.
Okay, I'm not able to see anyone. That's why. Okay, fine. Yeah.
No.
Yeah. Am I audible now? Yeah, I'll talk about the reversal of diabetes. It's all over the social media. If you open Instagram or Facebook or anything, YouTube, it just pop. They just pop in. The reversal of, everybody is talking about the reversal of diabetes. So today I'm going to talk about my take on reversal of diabetes. Is it that easy? Is it possible to reverse diabetes to everyone? This is the topic I'm going to talk about. So is diabetes reversible? Before going into that reversible of diabetes, I want to talk about type 2 diabetes. See, type 2 diabetes has long been regarded as inevitably progressive, requiring increasing number of tablet oral hypoglycemic agents and eventually insulin. So the 50% of the individuals require insulin therapy within 10 years of onset of diabetes. This seemingly makes this disease, the condition is treatable, but not curable or reversible. So is it easy to reverse diabetes like everybody says or everybody talk in social media? No, it is not that easy, but it is a very controversial topic. But yes, it can be reversed, but not to everyone. I will put it in that way. So all type 2 diabetic individuals cannot be reversed. First of all, let me talk about types of diabetes. There are many types of diabetes, but majorly it has been classified into type 1 diabetes, type 2 diabetes, gestational diabetes, that is diabetes during pregnancy, which is elaborately described by Dr. Uttara, and the diabetes which is caused because of, we call it a secondary diabetes, that is drug-induced diabetes, or stress-induced diabetes, or diabetes associated with genetic syndromes like Down syndromes and Dead-Mood syndromes and other syndromes, and diabetes associated with the the pancreatic calculus, some pathology in the pancreas, like calculi in the pancreas, or some tumor in the pancreas, a cyst in the pancreas. In that case, we'll remove the pancreas. Ultimately, they end up having diabetes. So there are different types of diabetes. So we can't reverse every type of diabetes. So what is type 1 diabetes? The insulin, the pancreas is not, the beta cells in the pancreas are very ineffective, or there is an absence of beta cells in the pancreas. There is an absolute insulin deficiency. So they need insulin forever for the treatment of diabetes. So that kind of diabetes, type 1 diabetes, cannot be reversed. And some other types of diabetes, which I was talking to you about, like pancreatic calculi diabetes or diabetes because of some pathology in the pancreas cannot be cured or reversed. It is very difficult because there is some problem with the pancreas which is not curable, which is not treatable. We cannot remove the stones like kidney stones from the pancreas. So it is not as easy as we think. And gestational diabetes, it's a kind of diabetes which get reversed because in some patients, 50% of the patients that if there is no positive family, strongly positive family history, or if they are not very obese, if they can bring back the body weight to the pre-pregnancy body weight, the gestational diabetes can be reversed. And so now we talk about the type 2 diabetes. So in type 2 diabetes, there are different types. So there are 4 subclusters of diabetes are there. That is subtypes are there. In 2 diabetes, it's a severe insulin deficiency will be there. It's not complete absolute deficiency. There is some deficiency where they require insulin for the correction of the diabetes or the correction of the blood sugars. In that case, that kind of diabetes is not reversible. So in what are the patients we can reverse diabetes? So not all the patients can be reversed, but some patients, see that targeted diabetic patients with the help of the dietary interventions. So if it is implemented, that reversal is implemented within 6 years of diagnosis of type 2 diabetes, and ideally within 2 years, it is possible to reverse that diabetes. In those with better glycemic control, with the HbA, you cannot select a patient or target a patient for the reversal of diabetes if the HbA1c is more than 12% or 11% or 10%. If they have the ideal, HbA1c, that is, HbA1c is nothing but the 3 months controlled blood sugar. To know about the 3 months average, we do a test called HbA1c. If the HbA1c is less than 7%, that is ideal HbA1c recommended by many diabetic associations like American Diabetes Association, RSSDA, Canadian Association. If the HbA1c is less than 7%, it is easy for us to reverse the diabetes. In those patients on less medications, if the patient is having many medications, more than 5 tablets, more than 5 oral hypoglycemic agents, and 4 times basal bolus insulin, is very difficult to reverse the diabetes. In male individuals, why? Because the female body undergoes so many hormonal changes because of menstruation, because of pregnancy, because of gestation, so many other causes. They have so many multiple, the weight gain will be there, weight loss will be there, the hormonal imbalance is really going to affect the female body a lot. So in male individuals, it is easy to reverse the diabetes when compared to the female individual, but still it is possible. But when compared to male individuals, it is little difficult for the female individuals to undergo the reversal of diabetes. So in those with good insulin secretion, this is what I was talking about. So when you have a good insulin reserve, that is, if you measure your insulin with the help of C-peptide, that tells you how much insulin reserve you have in your body. So if that is good, then we can think about the reversal of diabetes. In those with less visceral fat. So what is visceral fat? That is fat in the organs, that is liver, pancreas, which is very important for the development of the diabetes, because studies says 1 gram of fat in pancreas, just 1 gram of fat in pancreas can cause diabetes. And the fatty liver can also, one of the reasons for the development of considered as one of the reasons for the development of the type 2 diabetes and the insulin resistance. So in those with good mental health, because we will be putting them on severe calorie deficit diet, and they have to follow the diet and diet regimen when you opt for the reversal of diabetes. So in that case, the mental health is also very, very important. So the evidence of effectiveness beyond 2 years is limited, but still it is possible. So what do we do to bring down that reversal, to bring back that reversal of diabetes? So we need, if the patient is obese, they need at least weight loss of 25% of the total body weight. That is, if the patient is about 100 kilograms, or they need to lose at least 15 to 20 kilograms to get into that reversal of diabetes. Otherwise, it is impossible, because the study shows, as I said earlier, the 1 gram of fat in the pancreas can cause, it's likely the type 2 diabetes is caused by less than 1 gram of fat in the pancreas. So you need to reduce 15 kilograms of weight to lose that 1 gram of fat in pancreas. Can you believe it? You need to reduce 15 kilogram of total body weight to reduce that 1 gram of fat. So you need huge weight loss to get this diabetes reversal. So, and one more point I need to highlight is, it is, so you need, you see, if the patient undergoes some bariatric, a kind of bariatric surgery, where you lose lots and lots of weight, then the reversal is possible. That's why the bariatric surgery is considered as one of the mode of treatment for the diabetes reversal. And in that case, if the patient is not obese or overweight, we cannot opt that surgery for the reversal. So this surgery cannot be used as a surgery for the reversal of diabetes, but in obese patient, this will help to lose lots and lots of weight, and thereby it will help them to go for the reversal of diabetes. In some diabetes, like drug-induced diabetes, like patients who are on steroids, long-term steroids for rheumatoid arthritis, or in that case, if they can go for some that low carbohydrate or very low calorie diets, if they're able to reduce the weight, even without those drugs, they'll be able to reverse the diabetes. Sometimes the stress-induced, some acute stress-induced diabetes. Even the COVID is considered to be one of the reasons for the development of diabetes. That acute stress can cause diabetes. Once that we get rid of the diabetes, the reversal is possible. So this is how we aim for the reversal of diabetes. And so how do we go about this? How do we go about the weight loss? Then I don't believe in any fancy fat diets, like, I don't want to name the diet, but it's kind of very low calorie diet or low carbohydrate, very low carbohydrate. Of course, we also advise them to have a low carbohydrate diet, but we will not advise them to go for a very low carbohydrate diet, like a paleo diet or a or a keto diet or Atkins diet, where they insist on taking very high protein, or general Botas diet. I don't believe in any crash diet, because sustainability is the key in weight loss. If you're not able to sustain that weight loss, then re-reversible possibility is there. So what is re-reversal? They will, somehow they will, in the first initial period, within 6 months of diagnosis of diabetes, they will try to lose all the weight, and they will get back to the ideal body weight, and they will get rid of this diabetes. But even if they gain 2 to 3 kilograms, then the possibility of re-reversal is there. So the sustainability is the key in weight loss. If they are not able to sustain that weight loss, the re-reversible possibility is there. So that is why I insist on some a balanced diet. Of course, a low carbohydrate diet. The carbohydrate is the reason for the high blood sugar. So low carbohydrate diet, and you have to maintain the negative balance. So to have a weight loss, we have to maintain the negative balance. That is the calorie negative balance. If the patient requires 1,400 kilocalories for the daily meals, and if they want to lose some weight, they have to have the negative balance. So if the body needs 1,400 calories, they have to reduce the calorie intake by 300 to 400 calories. At the same time, they try to burn 250 to 300 calories. So ultimately, they'll be having the negative balance. So that's when they will start losing diet. Because why do we fail in losing weight? Because we are not maintaining the negative balance in the calorie intake and the exercise. When we are able to maintain that negative balance, we'll be start losing weight. That's how we can aim for the reversal of diabetes. And
that's really lovely. Yeah, please.
Yes, no problem. Please go.
Yeah, I wanted to ask you one more question. Most of the people I've heard, when there's some family history of diabetes, usually what parents say to their kids, don't eat sweets, don't eat a lot of chocolates, because you might also get diabetic once you grow up. So is it a myth, or is it a reality? Intake of sugary products, does that really work? I mean, does it add on to somebody's, diabetes, to be prone towards diabetes?
Yes, I agree with this point, because if they have a strong positive family history of diabetes, that is both parents are diabetes or grandparents are diabetes, aunts and uncle, when they have diabetes, we call it as a strong positive family history of diabetes. So they are more prone to develop diabetes at young age. If both parents have diabetes, they have a 99% of possibility to have diabetes at the later age. So if they start taking care, see, we cannot prevent, this is a non-modifiable risk. See, the strong positive family history, a strong gene is called as a non-modifiable risk. So in that case, see, you cannot modify that your parents. So it's a non-modifiable risk. So you cannot prevent them from getting diabetes, but at least we can delay the progression of diabetes. So anyway, they are going to get diabetes, but getting at the age of 30, 35 is very difficult to treat because they have to live with that diabetes for rest of the life. So they have to take medication, they have to take insulin. Ultimately, in 10 years of time, they might end up in having complications like diabetic neuropathy, diabetic nephropathy, diabetic retinopathy. If we are able to put them on a proper diet and exercise regimen, if they are able to control their weight within the ideal body weight, then it will be easy for them to, at least we can delay the progression of the diabetes. We can delay the progression of the diabetes from the pre-diabetic to the diabetes. So in that way, my answer is yes, they have to restrict their calorie, they have to restrict their sugar intake, they have to find a replacement. If they can go opt for a healthy sugars, then they'll be able to maintain their weight at ideal body weight, and it's easy for them to delay the onset of diabetes.
Thank you so much, ma'am. It was really lovely hearing from you. And what all questions I had, you actually gave an insight about the entire thing with your speech that you gave it to us. I had a question from Dr. Manodeep. If he's around, Manodeep sir, you are there? Are you there on the screen? Yeah. So I had a question. I wanted to ask you about that. Do you remember the question that I'd asked you? Yeah. So I would really love to have the answer.
I think you were asking me about
the fluctuating diabetes. About the fluctuating. Yeah,
it's a very important.
I really would like to have it in a quick way because we are already crossing the time. We have crossed it.
Very short.
Yeah. Thank you, sir.
Because the thing is, before the advent of the CGM, we were not aware of that fluctuations and the danger of fluctuations in the form of different complications. But thank God that we are entitled with this CGM, and we can verify and we can examine and we can see and we can show the patient, see this much about your fluctuations. There is a fluctuation, the parameter is there, we call the coefficient of variations in this continuous glucose monitoring. So this coefficient of variation should be less. So what happens when we see these fluctuations, there is too much of fluctuations, timing range is very low and all, and too much of hypos, too much of hyper, then we usually study retrospectively by going through his prescriptions that what medicine he is taking. Do we need some modifications in the existing medicine? Do we need some modifications in the dose of the particular medicine? Do we need some modifications in particular type of medicines? Do we need some modifications in the insulin regimen in which the patient is on? Do we need the change in dose of this insulin, dose of a particular insulin? So all these can be done by going through this continuous glucose monitoring report and the timing range and fluctuations and all. And once we modify this along with the diet and the exercise, sometimes what happens, patients don't tell their family members that he has eaten something extra, especially with type 1 diabetes, that he has eaten something extra. They don't do the carb counting. So the doctors will be able to know that what is happening. Though we can see from the report that, there is too much of fluctuations. So apart from this medicine and the insulin modifications, the diet aspect, the exercise aspect, the stress factor, the lifestyle factor, all these can be tracked down and we can investigate, we can post-mortem it, and we can come out with a very truth and fruitful conclusions that these are the things that we have to modify. Only then the variability can be reduced and the complications can be prevented. It is now very easy to quantify it, and accordingly, that's why we call it precision medicine. The precision medicine, precision therapeutics, precision diagnosis, precision evaluations and all. So it is amazing.
Thank you so much, sir. Can I have a look if Dr. M. Waliji is there? Because I was planning to ask the question from him, but I don't know if he's around. He said 5:30 he would be leaving. Wali sir, आप हैं क्या? Professor M. Waliji. I think he has left. I can see him. So can I just throw one question to all of you? Anyone can, just answer me a very short and quick answer that I would love to have. What kind of lifestyle would you suggest the teenagers now to follow so that they don't develop diabetes? Anyone?
That is a full topic as such for next meeting, I guess. But then, lifestyle,
Yeah.
it's just
A quick
healthy,
one.
healthy lifestyle. So when we mean healthy, it's quite subjective, So it's a calorie balance we take. So the energy intake and energy burning out. So if you're able to balance the energy intake and energy output, then you're fine. You're able to have a healthy lifestyle. The problem is, not many really read through the food label and so on. So they really don't know how much calorie they're taking. Being a diabetic is different. Prevention is a totally different. Being a diabetic is kind of in certain ways easier, because you know how much you should eat. You are monitoring your, diet, you're monitoring your sugar. So you can kind of balance. When you're not, you're going to prevent, you don't know. There is no guidelines as such, how much calorie you eat and all. But I would say first thing first, be a little cautious about the calorie intake and then have a regular exercise regime and have a good sleeping time. Sleep is very important. If you have to talk about the teens or the young adults, I think what they miss the most is sleep. I think rather than anything else. So I think a good 6 to 8 hours of sleep. There are enough data which shows that disrupted sleep or less sleep can lead on to diabetes, pre-diabetes, diabetes, complications of diabetes, and so on. I'm not getting into the numbers, but sleep is very important. Eating a meal on time, a healthy diet on time is quite important. The schedule is totally changed. They watch Netflix all through the morning and then, and the night get up and have junk food, napping Netflix and, no exercise kind of. There are a lot of myths which come up. Sunday means it's a Netflix, no diet and so on. So I think, enjoy life, of course, but then have some attention towards your health also, because that is kind of the foundation phase of your health. So that is when all your the chances of developing the NCDs, what we call the non-communicable diseases, happen. So if your family, like Dr. Lavina said, if your family has a very high risk, I think you should start monitoring also blood test and going out for checkups also if there is a very high risk. If not, at least exercise, whether they have a risk or not. As I said, Asian Indian have a very high risk, whether your parent is diabetic or not, very high risk. And the activity levels should increase.
Yeah. Thank you so much, Dr. Rutra. Thank you so much, because I really think this is a vast topic and we are having so many queries also, which I'm not able to take up here just because of the shortage of timing. We'll be taking it again in the next series. We are going to follow the series in the future also. So I would really thank all the doctors who were there on the panel. I would like to thank Dr. M. Wali, Rajiv Naji, Dr. Uttara, Dr. Manodeep and Dr. Lavina. You people were lovely. You gave us an insight, and it was really so, it was something educational that we got. And I think the youngsters should follow, because we really don't want to be considered as the, diabetes capital. And the research that has, come out that by 2025, the country is really going to be in millions now. This is something very alarming, and we need to take care of everything. So on behalf of Afzal Kamalji, I would really like to thank each one of you. He's not around today. He's somewhere occupied. So on behalf of Afzal Kamalji, I would really like to thank each one of you. And again, the series was organized by Medgate Today, supported by Hindustan Syringes and Medical Devices, and it was powered by Dr. Mohan's Diabetes Specialty Center. Thank you, everyone. And I really regret, and I'm sorry, I couldn't take all the questions, but the insight was lovely. It was covered in a very lovely manner by each and every expert of ours. So thank you very much. Thank you, doctors. Thank you, everyone.
And Yovita, thanks to you also.
Sir, आप हैं? अरे मुझे आपसे सवाल पूछना था. You're there. Oh my God, I was looking for you, sir.
There. I was throughout.
Sir, एक question आप मुझे पहले बता दीजिए. उसके बाद ही I am going to end up the show. दो मैंने सबको thank you बोल दिया है, पर अब आपको देख लिया तो I have my question. Medical science has, worked so much on everything. We have got so much of awareness everywhere. ऐसा क्यों है कि डायबिटीज की दवाइयां ताउम्र खानी पड़ती हैं?
क्योंकि खाना ताउम्र खाते हैं. इसलिए
simple.
But I will tell you one thing very interesting. आपका पेट आपका हंसते हंसते जो है दुख जाएगा. आपको पता है नॉर्मल शुगर कितनी होती है ना? 100 मिलीग्राम एवरेज. ठीक है, तो 1 लीटर ब्लड में 1 ग्राम हो गई. 5 लीटर ब्लड होता है टोटल. हम और आप जो बात कर रहे हैं, हम पूरा 1 चम्मच शक्कर पे चल रहा है हमारा पूरा ब्रेन सिस्टम, हार्ट, एवरीबॉडी, मसल, एवरीथिंग. 5 चमचा शुगर अगर हमारे शरीर में है, 1 चमचा यानी 5 ग्राम, हम उसमें पूरे दिन कितना डालते हैं भाई? इतनी पूरी में उंडेलते हैं कार्बोहाइड्रेट, कितना हम डबल रोटी में उंडेलते हैं, कितना बालूशाही में, रसगुल्ला में, एवरीथिंग वी आर उंडेलो, and we are producing diabetes. We are glucotoxicity is the crux of the matter. We are producing glucotoxicity, and this nobody points out. This was very interesting to know that we are just running our show with 1 spoon of sugar and how much we add everybody to our body. And the solution is either medicine or exercise. There is no third solution. And that is how it is. So if one has detected diabetes, we are talking about reversal of diabetes very stringently, but the reversal of diabetes is the reversal of your habits, your day-to-day routines, your type of food, and stress. Stress is also very important. So I have seen many people whose diabetes goes haywire. They are under stress. There is hyperglycemia. And they have got some undiagnosed endocrinopathies other than pancreas disease. And their sugars are haywire. You give them best drugs, best insulins, and they are not controlled. And this is where our yoga helps. I think somebody has talked yoga. And our this lifestyle is a very, very simple word, but it is a great meaning. Lifestyle relates to life. We are shortening our life by doing wrong things every day, and our shortening of life is also by stress and lack of sleep. And these days COVID has done so much damage to all the organs. We have to work largely on it, that how much COVID has damaged to the people's pancreas, muscles. I am suffering because of muscle loss and so many things. You see, diabetes treatment is the education of patient. The 3rd year lecture, one of my professors, Shyam Sundar Singhal Saab, when he came to the lecture theater, 3rd year, first lecture on diabetes treatment, he said education of the patient. At that time, I didn't understand as a student, what does this mean, education of patient? कौन से क्लास में जाके पढ़ेगा? But actually, with each cup of tea, with each spoon of diet, with each step we take, is treatment of diabetes. And let it not happen in the future with the calculations which you have told in the beginning. A free of diabetes atmosphere is very difficult. You see, since diabetes is known since ages, there has to be some more research has to be done. What at those days caused stress? Those days were not of stress. So something has been there which we have not yet found out. We have found out very good drugs, and they have been speaking about good drugs, good insulins, newer insulins, SGLT2 inhibitor, cardiotoxicity reversed, cardiac failure reversed, and so many good things. Renoprotection is done. So one day we will be telling the treatment of diabetes is 1, 2, 3, 4 like that. But so long you have to take medication.
खैर आपने बताई दिया कि वी हैव टू टेक मेडिकेशन जब तक अगर हमने अपनी लाइफस्टाइल को कंट्रोल नहीं किया तो मतलब लाइफस्टाइल मैनेजमेंट इज द की फॉर गेटिंग रिड ऑफ डायबिटीज. एनीवेज थैंक यू सो मच सर. एंड आई वाज रियली फीलिंग कि मैंने आपसे क्वेश्चन नहीं पूछा. मुझे इस बात का बहुत मलाल था कि मुझे ये सवाल पूछना है.
No, I was listening to all the time. I was listening to all good speakers, and I thank them again on behalf of Medgate. And we should keep meeting more often.
Yes, sir, because this is a very vast topic, and जैसे कि capital है, तो we need more and more of awareness क्योंकि हर व्यक्ति तक ये message पहुंचना चाहिए. It should reach every individual. Only then we can control diabetes. अब आपने कहा lifestyle disorder है, तो only controlling can be done once we change our lifestyle. So thank you everyone. Thank you for being on the panel.
30 seconds. When I was a physician to Pranab Mukherjee, Pranab Da,
Yeah.
He used to walk every day 4 kilometers in Rashtrapati Bhavan. And never in 5 years I have found his sugar higher than 100.
Wow.
And whenever I have eaten with him, he would eat very little. So the bulk of the pressure on the body is by what we eat, how we eat, how quickly we eat. And I can swear by his diabetic control. 5, 4.7, excellent diabetic control. The only thing is our plate. Our diabetes starts from our plate. One day I was eating at India Habitat Center. One person took the dinner. I took a photograph of his plate. And he said, why you are taking photo of plate? I said, tomorrow I have a seminar on diabetes. I'm going to put this plate. That there are sane people who know how much to eat when it is free to eat. And I showed it next day. And he was the deputy editor of Times of India. None other than that. And he was happy to know that I was watching what he is eating.
So he was eating in a controlled manner. Had it been my plate, it would have been very embarrassing for me.
So we
Thank you
have
very much,
to note, eat well.
Yeah,
it is
sir.
cold weather in northern India, very cold wave, and it's very bad weather today. And
Yeah.
I had time because I had less patience because of cold. So I was
Yeah.
on the
Dr. Lavina wants to say something.
Yeah.
Dr. Lavina?
Nothing, sir. I just
Sir,
want to end the session with this note. This sitting for a long time, sitting is considered as induced smoking. So
Yeah.
be active, move a lot. So get into some activities like Zumba, dance, or walking, simple walking. So that can help us to reduce the stress and diabetes as well.
Thank you, ma'am. It was actually a pleasure talking to each one of you, knowing insight about diabetes and how to take care of our lifestyle. सब लोगों का बहुत शुक्रिया, तहे दिल से शुक्रिया. Thank you so much. We'll meet again, see you again, and learn more from you all. Thank you very much. Thank you.
So,
Thank you, Pleasure was ours. Thank you
Thank
all. Thank you.
Thank you.
Thank you. Bye.
Thank you.
Bye
Thank
bye.
you. Thank you.
you.